My name is Mary McKellar. I'm one of the HIV providers here. I'm a clinical researcher, and I am the moderator for this session. So it is my great honor. I'm going to read this because I have some interesting information here. It is my great honor to introduce Jacquelyn Clymore, who's a colleague and a friend of mine. And she has worked in the field of HIV for over 30 years. She first started here in North Carolina at the Alliance of AIDS Services, which was one of the first AIDS support organizations here. And she served in a variety of roles at the Alliance, ending as the executive director. And then in 2009, she took on the position of HIV, STD, and viral hepatitis director in the Communicable disease branch at the Division of Public Health for our state. And so, but what needs to be highlighted here is that Jacquelyn came into the job of being our state director with a lot of community level experience. And I think that that's a very important point and fantastic for us and our patients. And she saw the HIV epidemic up close and personal in New York City, is my understanding. And then again, working at the Alliance here in North Carolina. And this has proved to be a strength in many ways. And in speaking with her colleagues, to put this together, they told me some real clear examples. One, that she served as chair of NASTAD, which stands for the National Alliance of State and Territorial AIDS Directors, and in 2018, where she challenged her colleagues across the country to achieve health equality, to fight stigma and discrimination. She was also the lead in getting the CAPAS grant, which stands for Care and Prevention in the United States, and that was several years ago. It brought in several $1 million to our state, and it was really dedicated towards decreasing HIV rates among African Americans and Latinos. I've personally had the privilege and delight of working with her on an initiative which was the HIV criminal decriminalization that took place 2 years ago, and Jacquelyn was the major driver behind this initiative. And what we did is we changed the law so it was modernized, and now it reflects the science. And I'm very pleased to see her here today and hear about the newest initiative in our state. And one last thing too, I just want to read some quotes from your colleagues. And this is where you're going to want to run out the door. Genuine, a fierce advocate for people and communities that have been marginalized due to race. Humble, she just does the work because she has always deeply cared about people living with HIV and the people who work so hard to help them. She's devoted her career to this work. She's driven by her sense of what justice and fairness should be in our world. And it's her belief that everyone deserves to be heard and valued. She walks the walk. So it's my great pleasure, Jacquelyn Clymore.
Well, that was a lovely introduction, so thank you, Mary, very much, and I'm glad it wasn't worse. Reach out to colleagues and ask them for things, and you just never know what will happen, so thank goodness it was okay. So, but Mary's right. I've worked in HIV all of my adult life. Actually, before I started my career, I took a semester off of college back in the early 80s and found myself working in advertising in New York City. And it was there that I ran into HIV for the first time because I was surrounded, as it happened, by a bunch of gay men, and they were getting sick and they were dying. And it was taking about 3 weeks from the time they were in their office to the time they were gone. So that was quite the eye-opener, but it was also pretty interesting because what I heard from the straight colleagues all around us was, well, at least it's not our problem. At least we don't have to worry about this. And of course, biologically, that just didn't make any sense at all. You knew even in the early 80s that sex was sex and biology was biology, and whatever gay men could get, other people could get too. So it just didn't make any sense to me. So I went back and finished my senior year already knowing that somehow I wanted to be involved in HIV. It took a few years for me to make that happen, so I spent some time in advertising, as it strangely worked out. But then I moved to North Carolina and got a master's degree very specifically so that I could work with people who were at the time dying of AIDS, and met some fabulous people who were also breaking new ground, Dr. John Bartlett being one of the very, very first. I was running a hospice by that time, and I took care of a lot of Dr. Bartlett's patients, and we saw him and his wife Trish Bartlett all the time. But it was very much about taking people to the end of their lives, and that's all. So I was saying to my colleague as we were walking around upstairs, how amazing it is to me 30 years later to look at the posters, to see what you all are doing, to see the progress that we're making. Back then, nobody even talked about it, much less did research. I mean, it really was something that only the highest echelons of NIH and other places were really paying any attention to. And you wouldn't have been able to go to a lunch and sit down and see all the posters and see what everybody was doing. It's very exciting to see that. And we are at a very, very interesting time in HIV. So I appreciate the opportunity to come and talk to you all. I am not a scientist. I have a master's degree in counseling, which again, I did deliberately so that I could work with people who were at the time dying of AIDS. So this is not going to be a scientific presentation in any way, shape, or form. So if you were looking for that, you're going to need to go back up and study the posters some more. So many of those were way beyond my understanding. But what I do want to talk to you about is the efforts that we have underway now to end the epidemic of HIV. And this really is a lot more than just hyperbole. We are not just saying it. We're not just putting it up there so that it sounds catchy and it'll get picked up in the news. This is an effort that started really as a grassroots effort a few years ago. Some states and jurisdictions around the country started talking about a plan. I'm going to make a plan to end the epidemic. And of course, it was generally places like New York, California, places that have a lot of resources, a lot of money, have been dealing with the epidemic for a very, very long time. But others started to get on the bandwagon. And as Mary mentioned, I was involved with NASDAD, am involved with NASDAD, and have been on part of the Officers Corps with that organization for quite a while now. And I got very intrigued with the idea that North Carolina could also end the epidemic. So I started talking about it back in my office in Raleigh and thinking about what we would need to do to gather information to end the epidemic in North Carolina. As we started thinking about that and making solid plans to go into the community, last January, the State of the Union address was part of what turned into the federal response. So that has also now picked up the effort. And so there are certain states and jurisdictions, city counties, that are chosen to be part of the first wave of the federal 2030 plan to end the HIV epidemic. And I'm sure all of you know that. I'm going to talk a little bit about it as we go. But what I thought I would do is really twofold. I'm going to show you the slide deck that we've taken on the road across the state this summer. We are going to 10 cities. Actually, we've gone to 8 at this point, so we're getting to the end of that part of it. We're really trying to engage the communities across the state to get ideas from people on the ground, people living with HIV, people at risk for HIV, the providers, the social workers, the doctors, everybody involved in this work, about what they think we need to do to overcome barriers, to address the social and structural issues around HIV, access to care, health inequality, and then making sure that we align this plan, however it comes out in the end, to address those issues, whether we're looking at big places like Charlotte or Raleigh, or whether we're looking at Bryson City and Ahoskie and Elizabeth City. We've been going to those places too. Because we can't end the epidemic if we just look at our big cities. We're going to have to go a whole lot deeper than that, which means we have to think again about transportation, we have to think about housing, we have to think about stigma, all of those. So I'm going to show you the slide deck that we are showing to folks around the state. I'm going to talk to you a little bit about what the federal effort looks like. And then I'm really hoping that before we get to 2:30, that you will engage with me a bit and talk about what you know about ending the epidemic and where you see the concerns that we need to be addressing. We do not have new funding to do this. So the funding that we have from the CDC and HRSA, particularly the Ryan White funds, is the money that we will have to use. We're not getting a new bolus of money, which means we're going to have to slice our pie differently. We're going to have to stop doing some things in order to start doing some other things. But it's clear that the time is now to start doing this. It's clear that we need to make some changes in order to end the HIV epidemic in North Carolina. So let me go ahead and show you this slide deck. So we start here as we gather community engagement. Of course, we want people to join us. We put out a lot of PR, we talk to a lot of people, we publish it as far and wide as we can go. And we've partnered with the North Carolina AIDS Action Network, NCAN. That is the very large and well-established advocacy organization in North Carolina. They've done a lot of lobbying to the General Assembly. They have gotten us quite a lot of money, including for things like the AIDS Medication Assistance Program, ADAP, now called HMAP. And by the way, a word about language, we're ditching the AIDS word wherever we can, which is tricky because an A is a very handy vowel to have, and we've all built lots of words around it, like ADAP. But HIV is really the more accurate word to be using now. So wherever possible, we're not talking about AIDS, we're talking about HIV, because that is the medical fact about what we're dealing with now. And just that alone kind of gives me chills, because that's most surely not where we were, really not even 10, 15 years ago, but it's very much where we are now. So we're partnering with NCAN to do these community outreaches, and then they'll be working with us on developing the plan. As I said, there are state and federal efforts underway. It's our hope that the state plan will be rolling out in draft form in late December or January coming up. We have a fair amount of work we've got to do between now and then, but we're doing it. And then, as I said, the federal plan is actually tapped 7 states and 48 jurisdictions. North Carolina is not one of the states that was tapped. South Carolina is, and Mecklenburg County, Charlotte, is also one of those. Mecklenburg has already written a Getting to Zero plan, G to Z, and they're going to be augmenting that now that they're part of the federal effort. We've also created a partnership between North Carolina and South Carolina so that we can try to do some work across the border, and particularly around the border counties, and of course Mecklenburg is on the border. So we are hoping that between the South Carolina effort, the Mecklenburg effort, and our own North Carolina effort, that we'll really have an effort to end the epidemic in the Carolinas, an important piece of that plan for America. This is the graphic that the feds have put out, so you've probably seen this. It's ambitious. It's also, I think, pretty what one would expect: diagnose people who are living with HIV, treat them rapidly and effectively, prevent new transmissions with things like PrEP and syringe services programs, and respond quickly to outbreaks. And it's a good plan. There's nothing at all wrong with the plan. It's very good. I'm not sure that it fits with everything that we've heard from the federal government in terms of their HIV thoughts and expectations, but it would be awesome if we can do this. And I think that our plan will have some similarities. Those 4 pillars that they have there are certainly things that we do, including, by the way, syringe services, syringe exchange programs. How many of you are aware that syringe services exchanges are now legal in North Carolina? Good. It was illegal for a very, very long time. And almost 2 years ago, it's legal to have syringe service programs and exchanges in North Carolina. That's a critically important step also in ending HIV and hepatitis and so many other things. So that's one of the tools that we didn't used to have that now we do have. So these are the ending the epidemic efforts across the country. The blue states are the ones who have plans already. The blue dots are cities or counties that have plans already, and the green states are the ones who are working on it. So there we are. You'll also notice that the blue states are frequently Medicaid expansion states. In fact, I think all of them are except Texas, yes, which does help. If you have Medicaid expansion, you have a lot more options for medical treatment for people living with HIV than if you don't have Medicaid expansion, and I think that's also something you would all be aware of. So we created an Ending the Epidemic Steering Committee. We sent out applications far and wide across the state and asked people to invite themselves onto this steering committee. We got a lot of applications, so we had a lot of choice. And we were really able to sort that as widely as we could for diversity, and that was every kind of diversity we could think of: geographic, gender, sexual orientation, work, lived experience, life experience, all of that, and put this together and had all these folks come together and talk to us about what they thought the strategy should look like, and particularly look at what the pillars should be. What would our main priorities be, and then what would we build out under it? We will get this group together again when we have a draft plan so that we can show them where we are and see what thoughts they have going forward. I mentioned that we are looking at community impact, and so we designated 9 cities that we were going to visit. We actually added another one, so Rocky Mount got added later in the process. And we've gone to most of these now. We got Hurricane Dorian took us out of Wilmington, so we've got to go back there. And we're going to redo the meeting in Charlotte. We didn't have a very good turnout, and that was a little bit concerning to us, given that a third of the epidemic is there. So we're going to change where, and we're going to change when, and we're going to change the day of the week that we do it and all of that, and see if we can get a better community response, because we really would like to hear quite a bit from the folks in Charlotte, since there are so many people living with HIV and at risk for HIV. But we also took it just as far and wide across the state as we can, and as I was telling Mary earlier, it's about getting their input, and it's equally about making sure that people understand that when we talk about HIV, we don't just talk about it in Raleigh or Durham or Charlotte or Greensboro or Winston-Salem. We do talk about it in Swain County and in Elizabeth City and in Pitt County and all the way north and all the way south. Because again, we can't end the epidemic if we're not looking everywhere. So then we go on to some basic statistics, and I'm not going to spend a lot of time on this, but I'll kind of blow through these briefly. We want to try to level set as we go out into the community, and we ask them to help us build out our strategies. And so new diagnoses of HIV are coming down. They continue to come down. The last 2 years, we've come down and down and down, and that's great. But we're still having 1,400 new diagnoses every year across the state, which is far, far too many. We certainly can't end the epidemic with that kind of number. Likewise, deaths have come down a great deal, and this only goes from 2000 to 2017-18. The numbers, of course, before, and all this, was far, far, far different. So the good news is our green line around deaths is very low, but as far as I'm concerned, any death that gets reported that's HIV related is a failure of our medical system. It's a failure of our support system. It's a failure of everything we're trying to do, because there's no reason for it. Nobody needs to die of HIV in North Carolina or in the United States at all. But that's about the inequities of our healthcare system and our barriers to care. I was talking to the staff on our medications program yesterday, and they were talking about an expedited application that they were doing for someone who's been hospitalized, very sick, intubated. And he'd been diagnosed in 2008. He has 36 T cells, CD4s, and he's never been in care, not once, since his diagnosis in 2008. That's appalling. And I asked her to hang on to his information because I want to go meet him. I am going to trust that he is going to improve, but I really want to find out what that story is. Every time we hear about someone like that, I want to find out, or I'll ask the doctor, why didn't this person get into care? What can that person teach us about the barriers to their care? Was it stigma? Was it the bus? Was it nobody got him a good appointment? Was they housing? Was it childcare? What was it? What was it that kept this man out of care for 11 years until he wound up deathly ill in the hospital? Because we've got great medicine, we've got great doctors, we can fix this, but clearly we're not where we need to be. So we talked then with the community about who we need to reach, and of course anybody can get HIV, that's obvious, but people diagnosed in 2018 were much more likely to be young. They were more likely to be minority rather than rather than whites. They were more likely to be gay, bisexual, or other men who have sex with men. So they're young, they're men who have sex with men, and they're African American. Those are our highest diagnosing populations still today, and by a lot. So that's still the population that we need to focus on and look at. It doesn't mean it's the only population. African American women continue to be of concern. Young people continue to be of concern. But that population alone, it continues, and this is not just North Carolina, this is everywhere, continues to be the population that is getting diagnosed more than any other. We talked some about the other co-occurring diseases that happen. Syphilis in particular, 44% of residents in North Carolina who were diagnosed with syphilis also have HIV. These go hand in hand. Chlamydia, gonorrhea, also risk, and to some degree, hepatitis B and hepatitis C. Particularly with the opioid epidemic, it's a lot easier to get hepatitis than it is to get HIV, particularly if you're sharing needles. So as we watch the opioid epidemic continue to unroll, we have to think about the fact that both HIV and hepatitis are going to be part of what we're seeing with the opioid epidemic. Stigma. How many people don't think stigma is an issue? Don't raise your hand if you disagree, because I really don't want to know about it. I personally believe that if we could end stigma today, we could end HIV tomorrow. I really think that this is the key driver. It's the reason people don't go for testing. It's the reason they don't show up for a doctor appointment. It's the reason they don't take their medication. What if the person I'm living with finds out that I'm taking pills? They'll want to know why. They don't go to the doctor because Aunt Susie's working at the clinic, especially in our small places. They can't explain to their neighbor why they need a ride to the doctor every so often, or why they're always over at Walgreens picking up medication and pills. It's stigma. It's internalized stigma and it's externalized stigma. It's both. So it's a difficult thing to measure, but the North Carolina MMP Medical Monitoring Project is something that we've participated in for a number of years. It's a CDC project, and it's basically about interviewing people who are living with HIV and now to some degree people who are at risk for HIV and asking them lots of questions. So we've distilled down how we're going to measure efforts around stigma to these 3 questions. I've been hurt by how people reacted to learning that I have HIV. And the great thing there is 54% of people disagreed with that. They have not been hurt, but that means half of them have been. I'm very careful who I tell that I have HIV. 87% of people are careful about who they tell that they've been diagnosed with HIV. And I'll bet if they've been diagnosed with diabetes, the answer would be very, very different. It's one of the few diseases still that nobody's willing to talk about. And then having HIV makes me feel that I'm a bad person. Excellent news, 83% of people disagreed with that. 30 years ago, that was all they talked about. As I worked in a hospice and held their hands, there was so much guilt. There was so much, I'm bad, I know I'm bad. I'm hearing it from my family, I'm hearing it from my faith community, I'm hearing it from my friends and relatives. How could I let this happen? So the fact that 83% of people didn't feel that way in these surveys is encouraging to me. But it really should be 100%. It really should. So we have a lot of work to do on stigma, and everything that we're going to do in our plan is going to have to be through that stigma lens. What does this thing do to reduce stigma for our community? The care cascade. I know you all know about this. This is our most recent care cascade. We have close to 36,000 people who are diagnosed and reported with HIV. And let me pause on that for a moment. We have about 5,000 people who are not diagnosed and not reported. We are fairly certain that there's quite a crowd out there who does not know that they're walking around HIV positive, and we need to find them. We need to get them diagnosed, get them added to this cascade, and get them into care. But right now, close to 36,000 people who are living with HIV in North Carolina. 74% of them made it to one care visit, 70% made it to repeated care visits and are considered retained in care, and 63% are virally suppressed. Viral suppression is the holy grail of HIV now. We want everybody to be virally suppressed, to go to the doctor, to stay at the doctor, and to get their medication and take it. That is one of the key ways that we're going to end the epidemic. But if you turn the continuum upside down and look at it this way, here's the work we have to do. I mean, the great news is we've made great progress, particularly with an idea that's not all that old. But we still have 26% of people who have never gone to the visit, like the gentleman I mentioned earlier. We've got 30% who are not staying in care, and we have 37% of our diagnosed folks, plus the 5,000 who don't know they're positive, that we need to get into care and onto medication so that they're virally suppressed. Until they're virally suppressed, they are going to be unwell, and they have the ability to transmit HIV to other people. So when we talk to the communities about this, this is a really important concept that I want people to understand, and I'm glad people often say, yes, I've heard of this, but we've also had some folks who come to our meetings who have never heard of this, including people living with HIV who have never heard of this. So we've got work to do on how we explain this. We were at Rocky Mountain last night, and one of the folks that was talking to us, one of the community members, didn't know what the word transmission meant. Tiffany, my colleague here, Tiffany Corbino, is helping me with this. Tiffany was talking to her, and we talk a lot about what language we use. Transmission was a word that she didn't understand. It's something you do with your car. It wasn't anything to do with HIV. So as we roll out this plan and as we think about talking to people, we've got to find the right words too. And I don't know what the right word is to substitute for transmission. So we're going to have to, I think we'll have to go back and ask her what she would suggest we use instead. So PrEP, new tool for prevention, pretty exciting, works like a birth control pill. Take it once a day as prescribed and you will not get HIV. A lot of stigma around PrEP though. A lot of conversation about whether it's right to take PrEP, whether you should take PrEP, why are you asking for PrEP? It's the echoes of the stories that my mother used to tell about the birth control pill. Can't give you that, little lady, you get all frisky out there. I should ask your husband if it's all right for you. You know, that's stuff from the 50s and 60s, and here we are, a pill that prevents HIV. I used to dream of this idea. I would show up at the Duke ID clinic and bring Dr. Bartlett more and more patients and dream of the day when we could stop this thing. And a pill that prevents HIV is really awfully damn close. And yet, we're having a lot of trouble getting it to people. The dark green is best, light green is worse. We're somewhere in the middle. Right now, or in 2017, about 2,100 people who were on PrEP, but close to 46,000 people who we estimate need to be on PrEP. Insurance covers it, Medicaid covers it, Medicare covers it. So our issue really is uninsured people and the fact that we don't have enough medical providers who are offering it. And you have a poster upstairs I saw that studied that was very, very interesting. Very few doctors want to prescribe PrEP, even though it really is not complicated. So one of the things we're going to have to do to get more PrEP into more people is to make sure that we have more providers who are willing to prescribe it. And right now, we don't have nearly enough. So some of our current efforts and things that we've been doing at the state level, we have regional networks of care and prevention. This is how we get Ryan White funding, CDC prevention funding out across the state in these regional networks of care to provide services. Our HMAP medication program, as I mentioned, for people who don't have any other kind of insurance. We have disease intervention specialists. Those are the people who go out, used to be called the sex police. You probably still call them the sex police. They're the people who go out and tell other people that you've been diagnosed with HIV or with syphilis, and here are some things that you're going to need to know. There's two really significant changes to that, though. One of them is that part of the job of a DIS now is to make an appointment right then, right there for that client to the place they want to go, and to try to make that a warm handoff to that first medical appointment. The other big change is what Mary mentioned earlier. We changed the control measures in North Carolina. It used to say you had to tell everybody that you were going to have sex with or share needles with that you were HIV positive, and you had to use a condom. That didn't fit the current science of all of this, so we really went pretty hard on to change what that looks like now. So the control measures for North Carolina now, and we are one of the few in the country doing this, fits with the science. If you are in care with your doctor, if you're following your doctor's prescribed regimen, and you've been durably virally suppressed for at least 6 months, you cannot transmit HIV to your partner, and therefore you don't need to tell your partner that you're HIV positive. That's the law of our land in North Carolina now. It's interesting to me that I get quite a bit of pushback on that at different times, and sometimes from doctors, sometimes from people living with HIV. This idea of viral suppression and U equals U, undetectable equals untransmittable, is still a very new concept, and I think it flies in the face of the stigma that we've all got under our skin somewhere. That someone living with HIV should tell everybody every time that they have HIV, even when there's no medical need to do so. So we did change the control measures, and that's part of what our DIS now tell people. Our bridge counselors pick up the work from DIS at that point and make sure that they got to that appointment. If they didn't, they make a new appointment, try to arrange transportation, try to overcome those barriers to being in care. We do regional quality improvement work as part of our Ryan White efforts. This is particularly clinical work to make sure that we're looking at how our Ryan White funded medical care addresses disparities, that they screen for STDs, they screen for hepatitis, that we work on viral suppression and other things. And of course, surveillance. And my surveillance colleague has a wonderful slide that I didn't bring that says basically surveillance is not spies. We try to make sure that people in the community really understand that using our numbers, HIV is a reportable condition, viral loads are reportable lab counts, that we use that to identify potential new outbreaks, and that we use it to find people who have fallen out of care and bring them back. Literally go knock on the door and say, you haven't been to the doctor lately, and we'd like to help you with that. I wish we had found that man that I was talking about earlier. Apparently we didn't find him. But we need to be knocking on doors when we can't find our clients any other way, to make sure that they are given every opportunity to come back into care, to be in care, to overcome the barriers that are preventing them from getting care, which means case management, of course. And then, of course, we use advocacy to support all of this and to make sure that we have the money and the laws to do it. So ending the epidemic, there's no one size fits all. We do a lot of planning with communities, with providers, with community leaders and academic institutions, et cetera, so that we do have that community engagement, that we're planning a realistic plan, we'll develop a written plan, we'll implement it, and then of course we're going to monitor and evaluate it. There will be an HIV Ending the Epidemic dashboard that will be public for people to see how we're doing with what we're doing. We talk to people about the fact that we do have these tools that I've touched on. Treatment as prevention, that's the viral suppression, pre-exposure prophylaxis, PrEP, and PEP, post-exposure prophylaxis. That these are the tools that have really changed the entire landscape around HIV. And then we do a few more slides that I throw in at various points in the meeting. This is 2007. The blue is men, the purple is women. And what you can see is that for newly diagnosed people, it's spread quite a bit across a pretty broad age range, from 20-year-olds to 49-year-olds in 2007. That's 2018. You see what it did there? I'm going to flip it back. 2007, 2018. This surprises people quite a bit, because what this is looking like now is that more and more of our new diagnoses, those 12, 13, 1,400 people diagnosed each year, are young. They're younger and younger and younger. And that is a problem. Again, we have changed laws in this state. Abstinence until marriage was the law that you had to teach in the schools. But we changed that, I think it was 15 years ago now. And now the law says you teach medically accurate sex education in the schools. But a lot of schools don't do that. It's rife with loopholes, and local school boards can jump through those loopholes and not teach it. And as we've gone around the state and talked to different communities, it's very clear that that's what's happening. And yet, this is what this looks like. So one of the suggestions we've been making to communities is, take these two slides, show them this one, and then show them that one. And show them what's happening, because you really can't say it's not a problem. It's a big problem. And this is when they're diagnosed, not when they're infected. Some of these folks, some of these kids were infected much, much younger than 20 to 24. So, and this is not people born with HIV. These are people newly diagnosed with HIV. So the issue of reaching school boards, that's going to be a local effort. In order to address this issue, we can put all the billboards and all the bus wraps we want, but we're going to have to also address this with the kids where the kids are. And in social media and apps and Instagram and Twitter and all those things. And we all talk about this. This isn't news, but this is kind of the proof that we have to do it. And it's the proof we're trying to show communities as well. We talk about health disparities around race and ethnicity, and I'm not going to dwell on these because I think these are all very familiar to you all, but Black and African American people have by far the greatest rate of HIV compared to any other population, and by a significant margin. People of color in general have a much higher rate of HIV than whites do. Sexual orientation, same thing, 65% of our new diagnoses are men who have sex with other men. So within that context, what does that actually look like? And I touched on this in the beginning. They tend to be young. They tend to be Black and African American more than any other group. Latinx men are actually following along more and more with that issue, and white young men are not. So we know this. This is the population that is most at risk and that we need to be most concerned about. They're also the most marginalized. They are the people least likely to have health care, be able to access health care, be able to get medication, be able to overcome their barriers, living in rural populations, unable to get to the doctor, unable to get to a test. So all of that has to wrap around. Other diseases, as I mentioned, people diagnosed with syphilis, this continues to be a concern. We continue to have a pretty raging syphilis epidemic in North Carolina and around the country. It just seems to be one of those things we are never going to get rid of, but it's particularly true in people living with HIV for obvious reasons. Hepatitis B, C are both also issues that we're concerned about, and you can see that with the Venn diagram there that they overlap to some degree. So when we test for HIV, we want to be certain we're testing for syphilis, gonorrhea, chlamydia, and hepatitis B and C. C is curable. B has a vaccination. And I vividly remember, John, many years ago, you were delivering a lecture to those of us who were caregivers in the early days, and you talked about the fact there's a vaccination for hepatitis and nobody ever gets it. So what are we going to do when we finally have a vaccination for HIV? No one will ever get it. And I thought that was absolutely stunning, and it stayed with me all those years, and it's certainly true. So many people don't get a vaccination for hepatitis even though they're at risk. Their doctors don't suggest it, even with the schools now requiring it. There's a huge number of people who aren't getting it. It's part of what we're trying to do as we deliver medical care to people who are affected by the opioid epidemic. They need vaccination. So, pillars to end the HIV epidemic in North Carolina, and don't panic because I'm going to break these down in a minute, but this is everything at the moment. We have 3 pillars. The first one is to engage and embrace people in care. This is about increasing viral suppression. These are the strategies that we came up with the help of the steering committee and then with our first community meeting. I don't know that any of this is really going to be earth-shattering. I don't know that any of this is going to be, oh my goodness, how come we've never thought of that before? But what we're asking communities to do is to go through each one of these strategies under each of these pillars and tell us how we should do this. We're collecting the information. Tell us how we should increase funding efforts. Tell us how we should do patient navigators, peer support. Tell us how we should build better healthcare systems, et cetera, et cetera, et cetera. And then we ask them, of course, to tell us what are we missing? What's not on this slide that should be on the slide? Eventually, these will be the strategies under our first leg of the plan to engage and embrace people in care. It does occasionally bring out some very interesting things. It's very clear that we are going to need to fund peer navigators. We've never done that, and we're going to need to do that. Because one of the things we hear over and over and over, again, not really earth-shattering news, is that people living with HIV are most likely to listen to other people living with HIV. I think we're all like that. So talking to someone who's been there, I mean, that's the AA model and the NA model. You know, you get a mentor who's been where you are and who helps you with it. We don't fund this in North Carolina right now, and I think we will be funding it in coming times. It's clear that that is an effort that could take us a long way, and there's been some very, very good and very interesting studies about it as well. So we ask folks to look at the strategies and then tell us what else is missing. The next one, test and treat, identifying undiagnosed people, those 5,000 people living with HIV in North Carolina. That also involves PrEP. It involves the population of people not just living with HIV, but who are greatly at risk for HIV. It used to be when people were tested for HIV and they were negative, we would say, great, keep doing what you're doing, bravo, keep doing it. Not really a terribly effective strategy for helping people stay HIV negative. So now one of the things we need to do is that, but also we need to be saying, have you heard about PrEP? Let us link you to a doctor, if we have one. All you doctors out there, please. We need to link you to someone who can talk to you about PrEP and the possibility of whether it's right for you, and then help you walk through the process of figuring out how we're going to pay for it. This year, for the first time, we actually are funding PrEP navigators. We have 1 at the state, and we have 4 in the rest of the state and the community. And I know there are several other places, including Durham, who have funded their own PrEP navigators. So it's happening. It's rolling. I feel like we're a little bit low on the uptake on that, and we need to be moving a whole lot faster. We know there's a lot of people who would like to have access to PrEP, and they don't have it yet. Interestingly enough, the patient assistance program through Gilead, who makes Truvada, which is PrEP, is very generous. Paying for the medication is actually not the biggest problem. Finding the doctor who's going to prescribe it is the biggest problem. And then, of course, you have to go back. Unlike birth control pills, we are not yet prescribing it for people for a year. Though I understand that's coming, as is injectable PrEP and PrEP that will last 3 months, 6 months. So all of these great things are in the medical pipeline, and that's exciting. But right now, you have to go back to your doctor every 3 months. That's a potential barrier for sure. Again, we need to decrease stigma around PrEP and everything else. We need to reach marginalized people, and we need to particularly address people in the LGBTQ community, people of color, and communities have the greatest disparities. We're not going to end the epidemic if we don't pay attention to the folks who have been left behind in all of our healthcare system. Again, not rocket science, we know this. Policy and promotion is our last pillar, if you will, the idea of advancing support toward treatment and prevention. A lot of that is about healthcare provider education. We keep hearing two things about healthcare providers. They don't offer me a test or ask me if I might be at risk. Going with that actually is, and they never take a sexual history. Doctors are terribly, terribly uncomfortable talking about sex. It's like whatever goes on down there, we're not going to think about it. So we have that issue. The other issue that we have, though, with healthcare providers, and prescribers really would be the right thing to say, is the idea of language. We hear over and over again from the affected communities that we're using the wrong words. It shouldn't be HIV-infected people. It should be people living with HIV. We shouldn't be talking about people in ways that are stigmatizing, that create barriers. We should be asking you, what pronoun do you prefer? When I introduce myself in community meetings, I say, my name is Jacquelyn Clymore, my pronouns are she, her, hers. We should do that all the time. Doctors, prescribers, nurses, receptionists should all be wearing name tags that look like that. We need to pay attention to how we use our words because our population of people living with HIV and at great risk for HIV are already feeling terribly stigmatized. And we're helping that every time we don't pay attention to our language. We'll be putting that in our plan for sure. Condoms back into the schools, right? Yes, that would be awesome. If you go to the Chapel Hill Carborough school system, you can get a condom. I happen to know because I have a kid there. But if you go to most other places, or if you're out in Bryson City, you can't. And somehow we've got to figure out how to get those prevention materials back into the hands of kids, based on the slide I showed you earlier. We need to get people mobilized again. We've had a lot of conversation about the faith communities. And there was a time, and when I was doing the work in a community-based organization years ago, we had an entire arm of our agency that was the faith-based arm, where we did outreach to the faith communities, and we built care teams and all of that stuff. That has really gone by the wayside, and yet for a lot of populations, particularly African American people, it's one of the best ways to get information out there. But we've got to engage the pastors, or as someone told me last night, the first ladies, the wives of the pastors, to make sure that we go back to that idea of grassroots involves where we pray as well as where we play. We used to do it, and we've kind of strayed away from it. Housing and transportation is the other one that we hear every single time, no surprise. Housing in particular is a tricky one. We actually have quite a bit of money for housing at the state level through the Housing Opportunities for People with AIDS Act. But what we don't have is enough housing stock and enough coalitions and task forces in our local communities that want to address the issue of housing for people living with HIV. And of course, that's not just an HIV issue. You know, housing is healthcare, as they say, and that's true for any disease state, but certainly for HIV. You're not going to be able to have a very calm life where you can take your medication and get to your doctor if you don't have a place to live. And if you don't have a person you can live with who you can trust about your HIV status. So those are our pillars. Those are the categories that we are using to build our strategies for North Carolina's ending the epidemic. We ask people to put them on the grid of what's doable and high impact, but it's interesting because some of the things they think are low impact, I don't think so. And some of the things they think are completely not doable, I think are doable. So I was talking earlier, one of the ones that comes up a lot is expand Medicaid in North Carolina. I think that would be a reasonable goal, yes. But they tell us at the state level, please expand Medicaid. I can't expand Medicaid. The governor's in favor of it, the Secretary of Health and Human Services is in favor of it, but the General Assembly is not. y'all, have to expand Medicaid by voting. One of the things we can do to end the epidemic is voter registration. Put the right people in office who will do things like expand Medicaid. Because if we keep voting for the people who won't, we won't expand Medicaid. It's that simple. But it's a voter issue. Like so many things, we need to make sure people understand the power of the vote. So we ask people to provide their input and to get back to us using this email address, and I offer that to you all. I'm going to leave this up. Tiffany continues to check our email address. We get word from people after we've been to the communities who say, I've been thinking about it, thought about it more during the night, I have another idea. Sometimes we get please come back and talk to my church. That one's sitting on my desk right now. Please come back and do it again. We'll bring more people. So people have been very receptive to the idea of building a plan to end the epidemic. Now we've got to build the plan, and then we've got to execute it. That part's a little bit scary. But I want to stop right there because I'm very interested in your thoughts, your suggestions. What are we missing? What do we need to do differently? Thank you.
God. Thank you so much. That was fantastic. Very uplifting, too, to know the state's got our back here. So this is great, great news. And I do have two questions before we take questions. One's an easy question, one's a hard question.
Oh, great.
So my easy question is, are there federal monies coming towards the state from the ending the HIV epidemic that we keep hearing about? And then my second question is, one of the pillars in the federal plan is about responding to epidemics, and similar to what happened in Scott County, but then also what's happening in West Virginia too, which I hear is actually even bigger than Scott County. So do you feel like we have a plan to respond appropriately here?
So the first one, easy one, yes, maybe federal funds are coming. Federal funds are coming. In fact, they're rolling out now for the designated areas, the 7 states and the 48 jurisdictions that were chosen by the feds. There will be a second pot of money to them also. They say one day there will be money for the rest of the country, but we have no time frame on that. I don't think it will be any time real soon. I think for the next few years we are stuck with the money we have, unfortunately. The responding to outbreaks, we do that now. We have actually responded to quite a few outbreaks or potential outbreaks. Our surveillance system in North Carolina is dense and rich. We can see when it looks like an outbreak of many things are happening. We just intervened in a hepatitis A outbreak. We have looked at some hepatitis B outbreaks that thankfully were not. You'll hear about measles, for instance, has been a huge issue in a lot of places, some of our vaccine-preventable diseases. So we have actually all the technology we need right this minute for the outbreak response, and we do use it. It's kind of like, what was that, Y2K? It seemed like a big hoax when it became the year 2000 because nothing broke, because they fixed it before it broke. Outbreaks are sort of like that. So far, knock wood, we've been able to fix them before they broke. But Scott County, Indiana was a huge wake-up call to everybody. That was very scary. Scott County had 5 cases of HIV, and by the time they ended their outbreak response about a year and a half later, they had 192 cases in this one little tiny county in Indiana. They had no syringe exchange. Governor Mike Pence wouldn't allow syringe exchange, and they had a huge opioid-based needle-sharing intergenerational outbreak. Grandparents, parents, and teenager and adult kids who were sharing needles. And they went from 5 cases of HIV to 195. It was terrifying to all of us. And yes, there are other places, including West Virginia, where that's happening. Right now, we do it now. It may wind up, I think it will, somewhere in our plan, but we do it right this minute.
Yeah. Any questions out there?
Go ahead. Yeah, so Dr. Cunningham was saying, for those of you who couldn't hear, so many of the young men coming into clinic never got any education in school, were never asked what their sexual orientation was or what risk factors they might have, and what are we going to do about it? And it's huge. It's a huge problem. We were talking at, I think it was the Fayetteville meeting, I can't remember for sure, about the fact that, again, local communities are going to need to mobilize to address this. We're going to need to help them and put the tools, like some of these slides, in their hands to go to school boards or go to principals. Because yes, it's about condoms, but it's also just about understanding what HIV is and is not, how you get it and how you don't, that PrEP is available and where you can go to get it. Family planning clinics, STD clinics, Planned Parenthood are some of the biggest places that people are getting PrEP across the country right now. And a lot of men, including young men, are walking into Planned Parenthood saying, "Do you have PrEP for me?" So we need to make sure that they know that that's there. But right now, it's very hard to get much of this information out into an awful lot of the schools in North Carolina. So we may have to go back to some of our old-time stuff where it wasn't the schools, where it was the Boys and Girls Club or the Scout Club or the church youth group, et cetera, et cetera. Or we're going to have to go about it in some sideways fashion where it's we push to have it built into the health curriculum as opposed to the HIV curriculum. But I don't have a good answer for how are we going to do this, but it's very clear that we are going to have to do it. The numbers speak for themselves. They have indeed. Yes, indeed. I would love to see it mandated as part of the health curriculum, and we have talked about that. I'm not sure that our current legislature would mandate it, but again, voting is very, very important. I can't say it strongly enough. Yes, it would be awesome to make that happen.
Hi, wonderful. Guido Ferrari. You mentioned, I think you made a critical statement that if you break stigma, you will probably solve a lot of problem in the epidemic. But when we put the word stigma over there, is a word. And I would like, and this is a discussion to follow with Mike, who presented the last night at the community meeting. I would like you guys to present the stigma in a very horrifying cartoon, because the stigma, it's not just a stigma. If you agree, I think that the stigma comes from poverty and education. And you're not going to solve the stigma unless you're going to solve the poverty and education. Because it comes in Durham, is the same topic in Kigali, in Lusaka, in Accra, wherever the AIDS is flogging the population. So I think that, as you are saying, vote for the funds and everything else, there should be also a clear message when you guys are going around that you should vote for breaking poverty and making the education system better. Because it's not just a class who teaches how to use condoms and things like that. It's above and beyond that, if you agree. So
I completely agree. Yes, thank you. I think stigma also attaches, certainly in this country, and I think in many other countries, to our hang-ups about sex, sexuality, and sexual activity. You know, this is a sexually transmitted disease. We have so much trouble talking about sex and sexuality and who's sexually oriented where and all of that. The fact that HIV came to this country just as a historical accident, first among the gay population, brought us its own stigma, unfortunately, but that's of course not true in a lot of other parts of the world, and yet the stigma is the same. We are all hung up on this HIV thing, and I do think a lot of it is about the sexual part of the sexual nature of transmission of HIV. So we've got to deal with that, and yes, HIV is absolutely a disease of poverty, a disease of lack of education. As Dr. Cunningham was saying, kids being diagnosed have often not heard any of the information that they need to get. We had one mother in one of our community meetings recently who said she really didn't think it should be taught in schools because that was how it should be taught at home. And so she had opted her child out. She was in a school system where you could opt out of that particular part of education. So she'd opted her child out. So my question to her was, and then did you teach your kids about HIV at home? Did you teach them about sex and protection and all of those things? And her answer answer was no, because it makes me really uncomfortable to talk to them about it. So the kids didn't get the education, and we're back to square one. So yes, education and poverty are absolutely a huge, huge part of this stigma that we still deal with. No question about it.
Thank you for a wonderful talk, Lance Cooccurring Infectious Diseases. So I have a couple of questions, actually. First question, so this institution recently has made a pivot towards population-based health, population health. So what do you envision as the role of large healthcare systems with like multi-county catchment areas within the state to complement and augment some of your objectives that you've clearly articulated during your talk? That's my first question. Second question is, you know, I didn't really see much on provider education, and I know by the time you're a doctor 15, 20 years into practice, we kind of give up on you in terms of like behavioral modification and practice modification. And I think it's premature.
I'm sorry to hear that.
Personally, but,
Ouch.
but, you know, the question is, what do you think of a concrete example of like a campaign saying that PrEP care is HIV care, and that we should be reflexive in how we approach our patients, that every single patient that comes in as an HIV provider, every single HIV person living with HIV that comes in, I should be asking them the question, when I'm comfortable with it, or when they're comfortable with me, do you have any partners that would benefit from this intervention, quite concretely? PrEP care is HIV care.
Yes, it is, without question. We do, in a lot of places, and it can be done anywhere, we want our providers, whether they're actual HIV providers, general practitioners, whoever, when they see someone with HIV, or if they actually do a sexual history and find out they might be at risk of HIV, the second question really should be, and what about your partners? Have they been tested? When we test the partners of people living with HIV, we have our highest rates of positivity, which just is rational, just makes sense. But it's often overlooked in a medical office. And so, yes, we do need to be doing a lot more of that. We need to make sure that our prescribing physicians, prescribing people, are comfortable with both HIV care and PrEP care. It's not nearly as complicated as it used to be very honest. Not being a physician, I'm in no way saying, oh, it's easy, anybody can do it. But it's not the complication that it used to be. And if it's not a complicated case, it is my understanding that an awful lot of physicians could be treating HIV who currently aren't. And any prescriber can be treating PrEP. So yes, we do need a campaign. Maybe I'll call you back and we'll talk about that, because we're talking about campaigns. What are we going to put on the buses and the PSAs and the billboards? What's the plan going to look like? What are the graphics going to say? And how do we highlight things like PrEP as we also talk about viral suppression? Because it's a huge, huge gain that we have, finally, at long last, to have a pill that prevents HIV. So as we work toward what we're going to do about continuing to keep negative people negative, PrEP is the answer. We've been talking about condoms for a long time, and we want to keep talking about them, but it's not going to be the only answer. Your question about population-level health, the idea that large institutions are working in multi-county areas, of course, is wonderful, because they're often reaching counties that don't have medical care. They're reaching beyond their hub. Duke does this, UNC does this, lots of places do it, and it's incredibly important. But those satellite clinics can also become tricky, because the further you go out into more rural areas, the bigger the issue of transportation. And so it's great to have a satellite clinic somewhere, but if you still have clients who can't even get to that satellite clinic because of the rurality of where you are, you've got to address that within the practice. You've got to find a way that the case managers, and sometimes even the physicians, are thinking about, how's the client going to get here? What's the incentive for the client to get here? Some of you may know Dr. Michelle Ogle, who's been practicing up in Henderson at the Warren Vance Community Center. She started a food pantry in her clinic. And that's a heavy lift. I mean, literally, it's a heavy lift. I've run food pantries. It's a heavy lift. But basically what she did was stock up her clinic with food, and if you come to your appointment, you get to go home with a bag of food. If you skip your appointment, you don't. And when they call up and say, I didn't get to my appointment, but I'm out of food. She says, when you get here for your appointment, you will get food. She's also got her staff using texting to remind people. She uses Instagram and Twitter and all of those things to reach her clients. And she can prove that she's increased viral suppression and retention and care as a result of those 3 efforts. It's pretty impressive. It's something we can do and something we're going to have to do if we really want to address population level health. We're going to have population level answers as well. So I might call you, talk more. I saw someone over here. Yes, ma'am. Oh, sorry.
Thanks again, really great presentation. I had a question that was a follow-up question about education. There's a lot of evidence that education of providers and education within organizations doesn't actually lead to behavior change on its own. And so I was just curious, you have a lot of different, the 3 different pillars and a lot of different strategies under those pillars, but I wasn't seeing a lot of implementation strategies. They're more goals, right, that I was seeing in that plan. So I'm just curious if there's a model that you're planning on using, or if there are specific strategies, or if that's going to be tailored by location and how you envision that looking.
Sure. So what I showed you, the strategies, those are the strategies we're showing around the community, saying these are the things we think we have to address, and then we're asking them, what would you do in your place to address this strategy? Last night in Rocky Mount, they decided they might consider forming a task force to address the local school board around the issue of education in the schools. So we're asking them right now, what are your answers to implementing these strategies? But you're absolutely right. Any kind of meaningful plan has to show written strategies to address these. I think some of those will be very local. The way you might address that in the Wake County or Durham County schools is going to look really, really different than if you're addressing it in Catawba County or Cherokee County. So what we've said as we've gone around to the various jurisdictions is that we want them to think both statewide, but also think very locally. What will work for you here? Because what we might suggest from the state level about faith communities might be radically different from the way it would look if you're in Greenville. So we're going to have implementation strategies for sure, and we will. And I think some of those will then have to tailor to the individual communities that are going to be looking at this for certain. I think I'm out of time.
Yes. Well, thank you very much. Will you join me, please, in another round of applause for Jacquelyn? Appreciate it.